My topic of presentation is COVID tongue, a latest oral symptom. Coronavirus disease 2019 is an important threat to the global health. It is caused by severe acute respiratory syndrome, coronavirus 2. The first human case in world was reported in Wuhan City, China in December 2019. First case in India was reported on 30th January 2020. It was declared as a pandemic on 11th March 2020. The mode of spread is through respiratory droplets while sneezing, coughing and speaking, with the common symptoms being fever, dry cough, fatigue, sputum production, shortness of breath, muscle or joint pain, sore throat, headache and vomiting. The pathogenesis of the virus. The spike protein of the virus gets attached to the ACE2 receptors of the lung epithelium, resulting in downregulation of the receptors, which inhibits the breakdown of angiotensin II, which results in a cytokine storm with hypokalemia and vasoconstriction, resulting in development of acute respiratory distress syndrome, acute cardiac injury and acute tubular necrosis. In oral pathogenesis, the spike protein of the coronavirus gets attached with the ACE2 receptors of oral mucous membrane. The common sites of these receptors in oral cavity are tongue taste buds, gingival mucosa, buccal mucosa, tonsils and the salivary glands. The infection of the oral keratinocytes or glandular cells results in an increased permeability of the cell walls to the foreign pathogen with viral replication in the oral mucous membrane with ulcers and necrosis. A few oral manifestations reported in COVID patients were angular stomatitis, lingual papillitis, periodontitis, mucositis, angular cheilitis, candidiasis, gerastomia and chapped lips. The latest symptom. CDC acknowledges that it is still learning about the new signs, especially pertaining to oral cavity. ADA reported that they are tracking the development of these tongue issues. Genetic epidemiology experts from King's College London stated that 1/5 of COVID-19 patients experience few less common symptoms, one of such being COVID tongue. Signs are inflammation, small bumps, ulcers or blisters on the tongue, with furry coating which may be white or yellow in color which cannot be brushed away. Spectators estimate that 1 in 500 patients have reported these above signs. A few diagnoses made were geographic tongue, oral aphthous ulcers, scalloping at edges and macroglossia. A study conducted by a group of Spain dermatologists, 78 out of 666 COVID patients had oral cavity findings. Most common being dysgeusia, followed by transient lingual papillitis, glossitis with lingual lateral indentations, patchy depapillation, aphthous stomatitis, mucositis and burning sensation. Another study conducted by Iran researchers where they reported 170 cases with oral manifestations, out of which 75 were diagnosed with gerastomia, 71 with dysgeusia, 61 with candidiasis, 48 with change in tongue sensation, 28 painful ulcers, and 6 with recurrent herpes simplex viral infections. Features of COVID tongue are plaque-like changes in the dorsum of the tongue, etiology being candidiasis due to long-term antibiotic therapy and decline in oral hygiene. Aphthous-like lesions, multiple shallow ulcers with erythematous halo, yellow or white pseudomembrane on both keratinized and non-keratinized mucosa. Etiology was increased level of tumor necrosis factor alpha in COVID patients, which led to chemotaxis of neutrophils to the oral mucosa. High-risk category are older patients with immunosuppression and severe infections. Herpetiform lesions. Multiple painful unilateral round yellowish grey ulcers with the erythematous rim. Angina bullosa-like lesion. Asymptomatic erythematous purple blisters without spontaneous bleeding on the tongue. A few rare cases were reported. Melkersson-Rosenthal syndrome in a 51-year-old female who presented with malaise, unilateral lip swelling, fissure tongue and right facial paralysis. Strawberry tongue with cheilitis, glossitis, swollen tongue in a patient co-infected with Kawasaki disease. Atrophy of the surface of the tongue with white fungal patches in the left lateral side and a red patch in the hard and soft palate. Bilateral atrophy of the lateral surfaces of the tongue. The lateral dorsum appears depapillated with symmetrical distribution. Another retrospective cross-sectional study conducted by traditional Chinese medicine experts in 1043 COVID patients. The relationship between the tongue features and the patient's condition was analyzed. The tongue features taken were the tongue color, pale, light red, deep red and purple tongue coating, white, yellow and greyish black, tongue body shape into rough tongue, tender tongue, thin tongue, prickled tongue and fissure tongue, coating appearance into thin coating, thick coating, moist, dry, greasy, peeled or partial coatings. The results obtained out of the study were the patients with mild to moderate COVID-19 had light red tongue and a white coating, whereas the patients with severe and critical COVID-19 had purple tongue and a yellow coating. Greasy tongue was a significant characteristic of all the patients with COVID-19. Tongue color of young patients were mainly light red in color, whereas those with middle-aged and elderly were red and purple tongue. Proportion of patients with tender tongue increased as the disease progressed. A few management options for these oral lesions are chlorhexidine digluconate mouthwash, acyclovir for herpetiform lesions, photobiomodulation therapy, nystatin fluconazole for candidiasis, artificial saliva for xerostomia, systemic antibiotics for periodontal diseases, systemic or topical corticosteroids for EM-like lesions. I would like to conclude this presentation by saying that though such oral lesions are less common symptoms, they are becoming more frequent in some parts of the globe. Experts believe that these symptoms are currently being underreported as people usually don't realize that they are related to COVID. Also, the reasons for absence of sufficient scientific evidence reporting the oral lesions may be due to confinement situation, lack of access to tests, therefore diagnosis confirmation, and the fact that most dentists as a result of high-risk contagion have been out of the healthcare system. Thank you.